Hello, my name is Manel Luján. I'm senior physician specialist in respiratory medicine and I work in the Hospital de Sabadell, Corporació Parc Taulí, Spain. I'm going to speak about the use of the software of the Vivo 50. The use of the information provided by the PC software of the Vivo 50 may be useful in the daily clinical practice for adjusting non-invasive ventilation. I usually download and read the records of the patients with non-invasive ventilation being uncomfortable with the ventilation or in those patients with lack of improvement of arterial blood gases. I will show you some examples of how this information has helped me in the treatment of these difficult to ventilate patients. The first case was a young male aged 30 years old, morbidly obese, that was admitted in the emergency department. He complained of increasing dyspnea and progressive sleepiness in the last 3 weeks. At admission, the respiratory rate was 30 per minute and the oxygen saturation was 75% breathing room air. A sample of arterial blood gases was drawn with the following values: pH 7.30, PCO2 76 mm of mercury, PaO2 44 mm of mercury, serum bicarbonate 36 millimole per liter, and an arterial saturation of 78%. Non-invasive ventilation was initiated in the emergency department with the following parameters: mode in pressure support with an inspiratory pressure of 20 centimeters of water and an expiratory pressure of 5 centimeters of water. He was then transferred to the respiratory ward to continue with non-invasive ventilation with the Vivo 50. We selected a dual control mode with target volume and a maximum inspiratory pressure of 24 centimeters of water. A new sample of arterial blood gases after 1 hour of non-invasive ventilation showed a pH of 7.34, a PCO2 of 68 millimeters of mercury, and a PaO2 of 74 millimeters of mercury, with an inspired oxygen fraction of 28%. The ventilation was maintained during the entire night, remaining the patient at the following day with mild respiratory acidosis. We downloaded then the information contained in the ventilator. In the records, we could appreciate continuous periods of oxygen desaturation during the night. These periods corresponded to tracings with marked reduction in inspiratory flow and absence of assisted breaths. All the cycles were controlled. In the 1-minute screen, we also could detect many ineffective efforts in the flow time graph. With this information, we suspected that the patient also had uncorrected obstructive apneas, and we decided to increase the expiratory pressure up to 10 centimeters of water, with an inspiratory pressure of 26 centimeters of water. A new record showed absence of desaturations, and in the 1-minute screen we can appreciate a regular respiratory rate with assisted cycles and absence of ineffective efforts. The second patient was a man aged 72 with spinal muscular atrophy. He was receiving nocturnal non-invasive ventilation through a nasal mask initiated electively 2 weeks before, with correction of the arterial blood gases. However, this patient was complaining that during the night he could not sleep comfortably with the ventilator because he woke several times during the night with excess of air. The information provided in this patient by the PC software revealed that there were several periods in the night in which the ventilator triggered breaths continuously at a frequency over 50 per minute, with large leaks and absence of effective flow. In the 10-second screen, the flow after the previous controlled breath remained positive, indicating that even in the patient's exhalations and due to the leaks, the flow was still going from the ventilator to the patient. With this information, we determined that the awakenings of the patient might be caused by auto-trigger of the ventilator, and we decided to change the interface by a neuronasal mask. With this change, the patient improved the quality of his sleep. The third case was a woman aged 65 with severe idiopathic kyphoscoliosis and chronic respiratory failure. We decided to start with non-invasive ventilation in pressure support mode, and having the patient a severe restrictive disorder, we decided to set a minimum inspiratory time of 1.2 seconds. These patients, during the adaptations process, complained that she felt uncomfortable with the ventilator because when she was trying to exhale, the ventilator still gave too much air. Then we'll download the information available during the adaptations process, and this is a sample of these patients, and you can see here in the flow time curve that reaches negative values at mid-inspiration, indicating that the expiratory phase of the patient was initiated whereas the ventilator remained in inspiration. In other words, the neural inspiratory time of the patients was shorter than the inspiratory time programmed in the ventilator, and we were causing, for that reason, delayed cycles. In this particular case, the problem was suppressing the minimal inspiratory time. In conclusion, the information provided by the Vivo 50 PC software might help the clinician in adjusting the parameters of the ventilator, especially in those patients with lack of improvement of arterial blood gases or feeling uncomfortable with the ventilator. Thank you very much for your attention.